Hello, everyone in the room and online, and welcome to the meeting. This is the 2022 World Bladder Cancer Patient Forum, taking bladder cancer patients' voice forward. As I said, welcome to everyone online joining us via Zoom and everyone here in the room in Paris. A huge thank you first to Cancer Vessie France, who has co-organized this meeting with us, and thank you for hosting us in this beautiful country. We'd also really like to thank our premier partners, Astellas, Bristol Myers Squibb, and Seagen, as well as our sponsors, Roche, Pfizer, and Merck, for helping us with this event. Of course, the scope and the content remains the responsibility of the World Bladder Cancer Patient Coalition. For those of you in the room, if you have any questions, please raise your hand and we'll make sure that we use the microphone so those online can hear us. Those of you on the Zoom meeting, there is a chat function, so please use the chat function also to introduce yourselves to each other, share where you are, and then ask any questions and we will bring those to the audience. So, welcome. My name is Lydia Makarov. I am the president of the World Bladder Cancer Patient Coalition and the chief executive of Fight Bladder Cancer. We'll also later have Laurie speaking. She is the vice president of the World Bladder Cancer Patient Coalition, and she also represents our member organization in France, Cancer Vessie France, also known as Association Les Urgences. So, World Bladder Cancer Patient Coalition. This is the global voice for bladder cancer patients. Until 2019, there was not one single organization to speak as the global voice for people living with bladder cancer. And now, the World Bladder Cancer Patient Coalition is an association bringing together representatives of national bladder cancer organizations. And you can see here that we do have members from around the globe, and we are continuing our work to make sure that we have members from all around the globe. And indeed, our mission is to foster an international community of people affected by bladder cancer. We advocate for access to the best possible bladder cancer information, support, and care, and we build alliances with policymakers, health professionals, academics, researchers, and industry. And I'm very, very proud of everything that we've been doing over the past year. And on your chairs there for the people in the room, we also have some information. And for those of you online, Alex will be presenting that shortly. So our next slide is a video message. So I will play that now.
Dear colleagues, dear friends, bienvenue à Paris, welcome to Paris. My name is Professor Morgane Roupré. I'm the chair of the GU Cancer Departments in Pitié-Salpêtrière Hospital in Paris, France at Sorbonne University. It is my task today to welcome you in Paris at the ESMO conference for the WBCP World Bladder Cancer Patient Forum, which is a great initiative because it will bring together all the actors of this threat against public health. Bladder cancer is the key issue. Nobody's talking about it. And you are doing a lot to move forward into the direction of a better, I would say, management of this disease. This is why the Patient Forum is extremely important, because together with patients, physicians, researchers, pharma company, you are going to bring new ideas, connect the history and the knowledge, and such a network is going to be an extremely powerful level of pressure on the authorities who are deciding to agree or to put on the market this treatment or this therapeutic option. So once again, welcome to Paris. Enjoy the discussion today. You have a fantastic 2 hours meeting, and please do understand that the discussion will not stop after this meeting, and it will be everywhere in the Congress, by email, using the social media. We need to move forward with the treatment of bladder cancer. Thank you for coming.
So thank you, Dr. Porte, for that. And now I would like to welcome Laurie. She has been elected our Vice President of the World Bladder Cancer Patient Coalition and is a phenomenal bladder cancer patient advocate. And it's wonderful to be in the same room with you again, Laurie, after a few years of working virtually.
Thank you, Lydia. Bienvenue à tous. Welcome to the World Bladder Cancer Patient Forum. Welcome to everyone from around the world, including our youngest participant ever from Australia. And of course, welcome to everybody from France. Even if you didn't travel far, we're really excited to have you here today. I'd like to extend a special hello to everyone who's joining us online. Please be sure to participate. Don't hesitate to use the chat box. I'm Laurie from Cancer Vessie France. I am a bladder cancer patient carer. Two members of my family have been affected by non-muscle invasive bladder cancer. Our organization in France was founded in June 2017 by a small group of patients. Some of our main missions include facilitating access to peer support so that patients and their families are not isolated with their illness. We also contribute to raising awareness about the causes and symptoms of bladder cancer. We hope to promote early diagnosis. We also advocate for access to existing and innovative treatments. This involves lobbying activities as well as participation in our national HTA process. The goal is to bring the patient voice to the attention of the institutions so that we can be heard when it comes to deciding about access to innovative treatments. Some of our activities include attending congresses, and we like to share information about bladder cancer research with our members. We have a newsletter for that called La Petite Goutte. We do patient and healthcare professional interviews. We also have Awareness Month activities in May. This year, for example, we developed an animated video in collaboration with AFU and our industry sponsors. So I'm really excited about today's 2-hour program. From personal experience, I can say that it's really valuable to network and learn from other patient organizations, and I'm sure it's going to be a really great session today. So now we're going to see a short welcome message from the president of Cancer Vessie France, Frédéric Merlier. Regrets he couldn't be here with us today.
Au World Bladder Cancer Patient Forum 2022 et Welcome to France pour ceux d'entre vous qui ont voyagé de l'étranger. Comme beaucoup d'entre vous le savent certainement déjà, chaque année dans le monde, il y a presque 600 000 personnes qui reçoivent un nouveau diagnostic de cancer de la vessie. Cancer Vessie France est très honoré d'être co-organisateur de cet événement sur le thème « Porter la voix des patients atteints de cancer de la vessie ». Je regrette de ne pas pouvoir y être présent physiquement cette année, mais je suis certain que la session de 2 heures qui vous attend cet après-midi sera l'opportunité d'avoir des échanges fructueux sur la façon de mettre la voix des patients atteints de cancer de la vessie en lumière. En tant que président de Cancer Vessie France, toutes mes actions sont guidées par un principe. De quoi ont besoin les patients? Comment mieux servir les patients et leurs familles pendant leur parcours avec le cancer de la vessie? Nous avons ce fil conducteur en commun avec toutes les organisations membres de la coalition et nous savons qu'ensemble, nous pouvons faire la différence. Merci à la Coalition mondiale de patients atteints de cancer de la vessie d'avoir donné l'élan pour ce forum et merci à tous les participants d'être là. Votre présence est vraiment appréciée. Et votre engagement envers les patients atteints de cancer de la vessie sert d'exemple à nous tous. Merci également aux partenaires premium et sponsors de la WBCPC, sans qui cet événement n'aurait pas eu lieu.
So just to give you an outline of what we're going to do today, we will be presenting our bladder cancer patient survey results. Exciting. We have almost 1,200 responses from 49 countries. The survey covers 65 questions, and then we will go on to discuss the survey findings. And then we'll have a session on taking bladder cancer patients' voice forward through action. We're going to hear about different initiatives in different countries from our member organizations. Then we will touch on community support and advocacy projects leading change. And we will have a summary and conclusion. And I'm going to turn over the mic to the Executive Director of World Bladder Cancer Patient Organization, Alex Filichivas.
Thank you so much, Laurie, and thank you, Lady, as well, for your wonderful introductions. I would like to invite a clap to thank for this great opening. I can do that now. So thank you so much, and it's so great to see all of you here today. Thank you so much for those who are joining us online as well. I'm very much I've been looking forward to this event for quite some time now. All of our member organizations haven't had a chance to meet in person for so long, so we had a really productive morning today. And so we welcome the wider group and community today for these discussions, and in particular looking at what have patients shared with us in our survey, and what some of the fantastic work that our member organizations are doing across the world. So my presentation today is titled Patients and Carer Experiences with Bladder Cancer, with the findings from a global survey. And as a World Bladder Cancer Patient Coalition, Lydia had made a nice introduction about the organization. Before the establishment of it, there was not really one organization to speak as one global voice on behalf of people affected by bladder cancer. And that is one of the reasons why we've set out why our founding organizations have set out to start the coalition. But in addition to that, we realized that also there is not enough insight and understanding on patient experiences around the world from their care and from their own experiences. And this is why we've set out to launch this survey, and to build up that understanding what it really is to be affected by bladder cancer in different countries, and what can we do as a coalition and as individual patient groups on the ground to provide greater support and advocacy. And bladder cancer impact around the world is no country is really not affected by it. You can see that there's a varying degree of bladder cancer incidence, but it's the 10th most commonly diagnosed cancer in the world, and it is significantly more common in the men, as many of you will know here, representing 75% of all cases. However, women, 1 in 4 of the patients will also be women. And what is interesting, later I will share with this with the survey, is that it uncovers some of the specific differences in care and experience that women do. As far as we know, as a coalition, the few studies have detailed so far the lived experiences of people affected by bladder cancer, and their caregivers as well, and this is why the survey has set out to do this. It is the broadest international analysis that we know of, and we've done some research in preparation for this project. The broadest analysis of bladder cancer patient experiences in terms of countries covered, the number of responses, and the breadth of topics covered as well. It was a very collaborative effort, so with our member organizations, with experts around the world, and with patients themselves as well. And so I'm very much looking forward to sharing with you some of these insights. Here, just very briefly, I wanted to give an overview of the respondent characteristics, because it sets an insight into what's to come in terms of the data that I will be sharing. So the most common initial diagnosis that in our patient respondents profile was non-muscle invasive bladder cancer, so that was 64% of patients. We have registered some progression as well from muscle invasive, from non-muscle invasive to muscle invasive, and more advanced disease. And most of our respondents' experiences are from the last 5 years, so it gives us insight into more recent experiences of these patients. Our survey was global in its hope. It was open to everybody, and no one country was excluded. The survey was available in 11 languages as well, and we you will see the representation on the slides of the countries that were represented. Of course, this is highly reflected as well of our membership organization who have been highly involved in distribution of the survey. Nevertheless, it provides a great insight into what patient experiences are in these countries. I think it's a stepping stone as well for us as an organization, for our member organizations to build a greater insight as well. What are the patient experiences outside the high-income countries? So I wanted to recognize that 93% of the respondents did come from the high-income countries. Just very briefly as well, the methodology before we dive into the findings. As I mentioned, the main idea of the survey was really to build a better understanding of lived experiences of patients and caregivers around the world. And it has followed a great sort of structure of research all the way to the reporting, which was led by IQVIA, who have developed and undertaken the survey. We have done great literature reviews, member interviews, really using that knowledge to build the survey and the questionnaire, which was then developed by IQVIA and disseminated by our members and partners around the world. And it's a project that's taken more than a year and a half now, so I'm very, very proud to be here today to share that with you. And as we dive into the data now, I just wanted to recognize some of the limitations, of course, as every research has, that whilst the survey was distributed online, so there's some access to people who may be digitally deprived or not used to online tools. Also, the languages that we wanted to make the survey available as much as possible to as many people as we could. We reached 11 languages this year, so obviously people who may not be speaking these languages were not able to participate in this survey. And also, I think in summary, that the survey data best describes situation in the developed world. So I've structured my presentation in 5 sections. For those of you who are here today, we do have executive summary printed, and we look forward to launching the full report in the coming weeks. So everyone who's here today and online as well, this is our first time that we are sharing this data set and the key highlights from the report. So in the area of awareness and diagnosis, our study found that prior awareness of bladder cancer remained low among the patients who responded to this survey. 54% of patients did not know the signs and symptoms of bladder cancer before diagnosis. And interestingly, 32% were better aware of bladder cancers, of symptoms of other more common cancers when compared to bladder cancer. In majority of in the 2/3 of patients, 67% presented with visible blood in urine as a symptom when they first visited their doctor, and 20% have said that they did not feel that their symptoms were taken seriously at the time of when they went to visit a healthcare professional. Over half of the respondents as well were diagnosed with another condition before bladder cancer, so that was 57%, and the most common, as we know quite well in the community, being a urinary tract infection as the most common one. Most respondents in our survey as well were diagnosed within the 3 months of first going to see a healthcare professional with their signs and symptoms. And our findings appear to be consistent with literature showing that women have greater delays in diagnosis and slower referral pathway to a specialist when they present with symptoms. If you look at 70% of people diagnosed within 3 months, the gender differences are quite visible, with 83% of males diagnosed with 3 months compared to only 70% of females. Another area that our questionnaire, which covered 60 questions, so it was quite extensive in terms of different experiences of patients along the care pathway, was treatment access. And you will see that the distribution at the bottom side of patient respondents in disease stage, the 64% was in non-muscle invasive bladder cancer diagnosis, 31% was muscle invasive, and 2% had advanced or metastatic disease. 58% of patients have said that they were involved as much as they wanted to be in making decisions about their care and shared decision making. Literature also shows that shared decision making where patients have a great understanding and great involvement in their decision making often have better outcomes and experiences as well. But as patients have said also in some of the comments that we had through, in addition to the data, so some of the questions, we had free text opportunities for patients to contribute. They have shared as well that time and attention was evidently needed for patients to better understand their care, to have a conversation with a healthcare professional, and these were oftentimes not met. Another area as well was the lack of patient group availability in some countries, and as a patient organization, as the coalition, this is one of our mission points to help support the establishment and growth of strong patient organizations who can then provide the support and information for people on the ground in their communities. When continuing on treatment access as well, 72% of patients reported that they did not experience any barriers in access to treatment. However, I would like to remind as well that the impact of responding characteristics coming from more high-income countries might have impacted this response, and this could be a different scenario in different settings, especially if we had, for example, a greater number of respondents from low and middle income countries or more remote areas, which would require more research to better understand this. Over a quarter of our respondents from the total survey as well had radical cystectomy. And these patients also have received an additional set of questions because we really wanted to better understand some of the specific experiences that they had and what were the areas where the expectations were not met. And one of the striking numbers from that piece of insight from patients was that 45% of the patients were not counseled on sexual side effects before the treatment, and 70, sorry, I've just lost the track of my thought here. So 74% of patients who had radical cystectomy also said that no other treatment option was discussed with them in order for them to retain their bladder. And that's another striking figure when it comes from radical cystectomy. Patients who had a radical cystectomy is this area of more discussion and more understanding for patients to be able to retain the bladder as well. I will not go into great detail into these numbers, but you can see some of the core insights of patients who had radical cystectomy, and in the final report we have quite a nice insight there into more details, which I think would be helpful and interesting for patient advocates, but I think all stakeholders here today in the room. Another area we looked at was supportive and complementary care, and interestingly, almost all respondents needed more information. That's 82% of patients who have responded to this survey. 64% were not able to get help and support for financial or employment support, so these are a more practical side. 53% contacted a patient organization or charity for support. And then later on, we also find that many of them do not get a referral to a patient group, even when a patient group exists. And I think this guides to the need to work closer with healthcare professionals in this area. However, I think one of the more positive findings that we had from supportive and complementary care, that 87% of respondents felt that they received enough support from nurses and allied healthcare professionals and other fields, and so that's a really positive finding there. Some patients also had to seek out their own information as well, and this is where patient organizations in particular are coming so valuable. When it comes to supportive and complementary care as well, we asked them what were the specific areas, and so in the full report we have more data and insights into this. And this, I just wanted to share some of the more specific insights where patients shared they needed more help and support, things like self-image, alternative complementary therapies, and financial employment. And this really, the patient needs really existed throughout the whole care pathway. So from the diagnosis and awareness clearly that we have indicated earlier on, all the way through to treatment and also afterwards. And respondents also described that lack of follow-up after the active treatment was concluded as very much lacking. As we looked as well, nearly 3/4 of the respondents did not receive the information that they needed, and half of the respondents who contacted patient organization for support have received the information and support that they needed. So this is a good indicator that we are on the right path, but there is many areas identified in this survey report on where we can do better. And interestingly as well, patients have shared how they prefer to receive the information. And so you can see here that majority seek information online, also prefer to receive information through a general practitioner online support forum. So there's a varied way of how patients prefer to receive that information, and so this is something that our community strives to achieve, working as a coalition and with allied healthcare professionals. There is really a lot of data in the survey, and we're really going to go very much top line results for today, and it will give you an insight. And in the coming weeks, I'm very much looking forward to sharing the full report and the full data set that we have. We've asked patients as well, what was the bladder cancer impact on their daily life activities, and things such as financial impact varied from patients' age as well in the disease stage across the board. Additional costs due to bladder cancer as well have caused financial strain to patients, and things from supplies or travel costs or the need for private care were highlighted by patients as the barriers. I'm recognizing that I'm nearing closer to the time as well of my session. One of the greater things as well when it came from impact on daily life, the emotional impact of bladder cancer was felt very severely across many aspects of life, and some of those were felt, 36% of patients responded, were felt in sexual performance. 26% of respondents also shared impact for the hopes for the future, as well as 27% sharing the stress, anxiety levels as well. Some more positively as well, patients shared in the comments as well, in addition to data, of how their view of life has changed, and in a positive way too. So there are some learnings and the view of life that the impact had more positively. But this is an area for support as well. The patients highlighted very much a need of emotional support. We couldn't have done the survey as well without talking about the impact of COVID. Of course, our survey took place throughout 2021 and early 2022, and talking about the last 5 years of patients' experiences. So therefore, we had a few questions as well where patients had shared, and this really varied. Majority of patients did respond that COVID pandemic had no impact or no significant impact on their care and treatment. But when we dive deeper to better understand patients' commentary as well from the experiences, it really varied where patients were based and how their hospital was impacted by COVID-19 pandemic as well. And lastly, this is the first time the bladder cancer that the survey looked at caregiver experiences on the impact of bladder cancer. And we did have some respondents who were responding on behalf of a patient, and so when they recognized as caregiver, they were able to answer some additional questions that were directed specifically for them. And the most striking finding, I think the area where we can do much more to support caregivers caring for patients, was that only 21% found all the information that they needed to help them provide that care and support. And they often lack this information of care, how to provide support for patients, but also how to look after themselves as well. And 53% have sought information independently on patients' behalf. And these caregivers provide care support daily for patients impacted by bladder cancer. And again, emotional impact of the disease comes through as much to patients as it does to caregivers, and that came out very much in the data from in our survey. And majority of, 29% of caregivers have been providing care between 2 and 5 years so far, so drawing really from extended experiences of care and that impact. So in summary, I know that we went through quite a lot quite quickly, so I invite you, those who are in the room, to also take the time to have a look at the executive summary. And all of you with us today online and in person as well will be the first ones to receive the survey, the full survey report once that is ready. And so just in summary, before I hand over back to Lydia, I wanted to highlight some of the call to action areas that we have identified through the findings and working together with our expert advisory committee that have been really fundamental to our ability to deliver this project, who have been there every step of the way. I will not go through every point here, but I think there is a lot of points for discussion for the panel that we will have later on today, so we're very much looking forward to that. And I would like to also thank our board members for the guidance, our member organizations, our patient advisory panel. Everyone had fantastic input into this project to get us to this big milestone today, and soon with the launch of the report, and especially to the expert advisory committee whose guidance was fundamental for us to achieve the successful project, and Dr. Ashish Kamat, who's been the chair of our expert advisory committee and guided us the most through this project. So he sends his regrets that he was not able to join us personally today, but Lydia had an opportunity to catch up with him online. So we had a short 10-minute video, sort of just to share his feedback as the chair as well, and have a discussion a little bit more deeper into some of the key findings that we have identified in our survey. So we will play that to you now before we dive into the discussion. So thank you so much for your attention. Thank you.
Hi, I'm Lydia Makaroff, the president of the World Bladder Cancer Patient Coalition, and we're very lucky to have with us today Ashish Kamat, who is the chair of the Expert Advisory Committee and has helped us with the World Bladder Cancer Patient Coalition survey. So Dr. Kamat, as the chair of the Expert Advisory Committee and as a healthcare professional yourself, how do you see the value of this project?
So first of all, Lydia, thank you for having me. You know, it's been a great honor and a privilege to be part of this very, very important project that we embarked on. And your first question is actually, one of the reasons we embarked upon this, because this project was very essential. I mean, we've always known that there's information about bladder cancer out there, but we've never really truly been able to quantify how much of that information was reaching the patients, their caregivers. And to be honest with you, until this project shed light on the matter, we haven't really known the impact of caregivers on how patients perceive their diagnosis, their treatment, their essential overall well-being. So very important project, and a lot of the information that we gleaned from it was actually surprising to a lot of us on the panel.
What was one of the surprises to you?
Well, so we always felt that maybe there was a underappreciation of the impact of the financial toxicity on the patients. We always sort of felt that the caregivers might benefit from more information and a little bit more direction, but the extent to which that affected our patients and their caregivers, and by caregivers, I don't mean the physician caregivers, but their actual spouses, friends, family, caregivers at home, was rather surprising. The other thing that was actually surprising was the number of times patients responded saying that they wished there had been better detection and screening of bladder cancer at an early stage, because that's one of these debates that we've had off and on over the last 30, 40 years. And it's gone through a whole pendulum swing as to whether it's cost effective to screen bladder cancer patients or not, But when you hear it from the patient saying they wish they had had their cancer detected early, either by early screening at high-risk groups or even by better education of primary care physicians who might have been a little bit more on alert when it comes to the signs and symptoms of bladder cancer. So some of those just validated what we felt about this, gosh, 30, 40 years ago, but then sort of forgot about it because that went out of vogue, so to speak, and everyone focused more on targeted therapies than more modern immunotherapy. But we forget, and we're reminded by this, that early detection and diagnosing cancer early is really very important, not just to our patients, but also to us to improve their outcomes.
So three of the main themes that emerged were early diagnosis, financial toxicity, and the effect on informal caregivers like family members, loved ones, and neighbors, and so forth. So perhaps we can explore each one of those three issues briefly. So when we look at early diagnosis, we also need to remember to suggest cost-effective solutions because they're much more likely to be accepted within the healthcare system. So you mentioned briefly about the lack of awareness of the signs and symptoms of bladder cancer, both in the general population and in the primary healthcare practitioner population. What can we do to improve that?
Yeah, so as part of this project, of course, we had to distill it down. It's a large document, but we had to distill it down into call to action, right? And one of the call to action items is to increase the awareness of bladder cancer signs and symptoms in general, but also specifically to primary care physicians. And I think a lot of this will not necessarily be something that we can go back and fix from a curriculum standpoint, but it's more raising awareness, having, I guess, symposia, public education forum, and reminding the primary care physicians, because they've learned this, it's part of medical school training, but with the amount of other diseases they have to deal with, sometimes microhematuria is ignored, or it's attributed, especially in women that have delayed diagnosis, to a menstrual period or a UTI. And that's just something that we would need to remind our colleagues that are in primary care and have a lot of other things that have to deal with, that just like colonoscopy has become standard of care, it's recommended at a certain age, screening for bladder cancer in the form of microhematuria testing during an annual physical is a very cost-effective way to pick up microhematuria. And then that's one of the early presenting signs of bladder cancer. Not every patient needs a full workup, but it's something that primary care physicians should be reminded of.
And what exactly do you mean by microhematuria?
Oh, yes, for our lay audience, microhematuria is the presence of blood in the urine that's not visible to the naked eye. So, of course, if you who are listening as a patient and you see blood in the urine, it's grossly visible to you. That's what we call gross or macrohematuria. And if it's microscopic, that's microhematuria.
Thank you. We also talked about financial toxicity. Is this something that you saw only in countries with low incomes or low income populations, or was this a finding that you saw across the board?
So, that's one of those things that we still have to do a little bit of work on. This gives us the groundwork, the hypothesis, and sort of some of the impetus to dwell into this further. But what happens is in countries such as North America or the UK or in Europe, where they have a lot of access to the latest drugs that are also the most costly medications, some of the toxicity could be driven by that aspect of things. In certain other parts of the world where just access to healthcare itself is a burden of financial toxicity, taking time off of work, taking family time off of work, all of that adds to the toxicity. So it's not clear yet whether it is a therapy-driven toxicity or an access or time off from work, a loss of productive hours that's the toxic nature of bladder cancer. But we know from studies that have been done in at least North America that bladder cancer is one of the most expensive cancers when it comes to US dollars from the time of diagnosis to the time of last needing treatment, whether the patient passes away or is considered cured, simply because of the prolonged follow-up, the expensive checkups, et cetera, that goes hand in hand with it. So we do have to adapt that financial toxicity solution to the geographic region from where the patient is hailing. But I think in countries such as North America, UK, and European continent, a lot of this will be to reuse the resources better and not waste resources where we don't need to be spending extra money. But in poorer countries, it might be something quite as simple as providing access to information, access to the caregivers, so that they don't have to make the long trek from a small village to a major city just to get information, which they could get locally.
Yes, absolutely. And the results from this study will help set the priority and the policy agenda for the World Bladder Cancer Patient Coalition the following years, and really help us identify what areas of unmet need priority action. And then finally, let's touch upon caregivers, as you mentioned, the informal caregivers, the family members, the loved ones, and the neighbors. Do you have a message for those people who are caring for someone who has been diagnosed with bladder cancer?
Yeah, I mean, absolutely. And when I see a patient in my clinic, I mean, I see the patients with their loved ones that are right there. One of the first things that I will do is involve everybody in the care of that patient. It's a team effort. I'm part of the team, the patient's part of the team, but their loved ones are an essential part of the team. And without the support and help of their loved ones, simple things such as making it to the appointment, but even more complicated things such as recovery from major surgery or recovery from intensive chemotherapy, keeping the chemotherapy regimens are often hard. And we lose sight of the fact that if a patient is prescribed a particular regimen but is not able to get the regimen appropriately, for example, the full dose of immunotherapy, some of that actually is because the patient may not have appropriate care support. So my message to the loved ones that are listening to this is that your involvement in helping your loved one go through the journey to beat this cancer is extremely important. And it is truly a team effort. And you're just as much a vital part of the team as us physicians and the patient, of course, that has the diagnosis.
Thank you, Dr. Kamat, for your insights and also for all your work as chair of the expert advisory committee on this project for the World Bladder Cancer Patient Coalition.
Oh, it's been my pleasure. I can truly say this was one of the most rewarding projects I've been involved with in quite some time. Thank you for having me.
Thank you. So now we have a panel session. Is that correct, Alex? Wonderful. Yes. So we'll have various speakers. We'll have Lisbeth, who is joining us online from the Netherlands, who is a patient advocate. We also have Dr. Duran here in the room from Spain, giving us the healthcare practitioner perspective. We have Sarah Cullen here from the European Association of Urology, working on policy, giving us the international policy perspective, and giving us the industry perspective as well. We have Stephen Head from Astellas as well. So I invite those speakers to come up and join us, and we will discuss the findings. And do we have Lisbeth online?
You have me online. Hi.
Amazing.
Hello,
Wonderful.
everybody.
Thank you.
Hi.
Hi. So we will start with the patient perspective. Lisbeth, perhaps you can briefly introduce yourself and speak from your perspective, your thoughts on the patient survey.
Yes, thank you. Thank you. And thank you for being there, be it on a distance. Thanks to the strikes in the Netherlands for public transportation. I am the president of the Living with Bladder and Kidney Cancer in the Netherlands. Bladder and kidney cancer are combined in the Netherlands as a patient organization. And I'm very happy with the survey and the report you have done, because it really brings to light the difficulties we all see and have in the awareness and the early diagnosis. and we see that it is very important that patients know and understand what the symptoms are for bladder cancer. And especially women, we see in the Netherlands, and we see it in the report as well, that as women go to the general practitioner, the GP, their house doctor, tends to misdiagnose women, especially when they are postmenopausal or during menopause, because the symptoms in females are commonly attributed to infections or gynecological GP issues, which delay diagnosis and treatment. And you see that in the data as well, that for women it is more difficult to get an early diagnosis than for men. So we see that it is very important that the general practitioner is more, well, educated and gets more information from specialists and healthcare insurers and patients, how important it is to look more thorough and be more aware of bladder cancer, to have bladder cancer more on their active brain and to think about it and not think about other things. And it's, as Alex already said, it is the 10th oncological diagnosis, so it's not a rare disease and that you could easily miss. So it is something that you should think of. And we see in the Netherlands that it takes some time to get to the specialists. And when they get to the specialists, for men and women, we see that the specialist, the urologist, is somewhat in a hurry. He wants to put some pressure on the patients, that he wants to treat them as soon as possible. And sometimes they really do forget to give them all the information they should know, especially about the impact on sexuality for male and female. And we hear from our male patients especially that if they had known what all the possibilities were, they should have chosen perhaps another option instead of a whole cystectomy, and with all the impact and influence they have, because after the operation, there is no returning back to before the operation. It is a done deal, and they were never really informed about what the consequences could be and what their options could be. So for us, we think it is very important that the specialists and the nurse practitioners take the time to inform the patients beforehand and not after the operation.
Thank you.
And of course, it is so important that they know there is a patient organization.
Yes, absolutely. Thank you very much for your insights, and we'll come back to you with some panel questions after we've heard the other panelists' perspectives. So perhaps I can ask Dr. Duran next to share your perspective on the results.
Sure. Well, first of all, thank you for having me here. It's a pleasure always, being in these meetings that I think are so necessary, and we're starting to see them a little bit more often, still far from what should be. I mean, first thing is congratulations. Great effort, incredible. You reach so many people, so many countries. I think the data is very relevant. Of course, there's a couple of, bias that are unavoidable. I think, there is a bias towards more urology rather than other specialties involved in the care of bladder cancer. A huge percentage of the patients that responded to the survey were patients with non-muscle invasive bladder cancer. And probably there is a little bit of bias towards the Anglo-Saxon reality, so more United States and the UK. And that probably has to do also with the responses around the financial toxicity. But even, keeping in mind those biases, I think the data are quite relevant, at least are quite informative to me. And they come to confirm something that we've been discussing before. And I have some memories from the European Urology Nursing meeting where we were discussing about the challenges that we confront when we are treating bladder cancer patients. And I remember we talked about a number of things, and one of them were information, communication. And these topics, I was taking notes because it was quite striking how this survey really reflects that those concerns that we discuss are real. People in the survey were complaining about lacks of information at different levels, and lack of information to the patient about the different treatment options. I was very surprised about 74% of the patients who had a cystectomy never heard about any other option. I think we need to work on that, definitely, because there are other options. And, we don't have any radiation oncology here, I presume, but, we could argue the validity of that approach in combination with chemotherapy as a bladder preserving strategy. So at least we need to discuss, which patients are good candidates, and, they need to hear what are the pros and cons of each treatment modality. So that was quite impressive. The other thing, it was no information on the side of the caregivers, and here is where, patient advocacy groups are fundamental, because you guys provide lots of information that normally patients and caregivers have difficulty to find. So congratulations on that. And the last topic, and it's been discussed before, is probably lack of information at the level of the general practitioner. So maybe we need to work also on that, and we need to approach from the different specialties, urology, medical oncology, radiation oncology. Maybe we need to talk more to our general practitioners and say, listen, don't value, a microhematuria, or don't take a gross hematuria as an infection in a male who is over 50 and has been smoking for 30 years, because most likely it's going to be something else. So don't delay the diagnosis. It was surprising in the positive way. The time from diagnosis to treatment, it was quite reasonable in the survey. That makes me happy. But again, we need to take into account the bias of the countries that were, more responders. The other thing, it was communication, and I will finish with that. And that was another topic we discussed in Amsterdam. And I've heard it here by the previous speaker saying, okay, it feels like the doctor has no time, and this is serious. And it's true. And it's true from both sides. The doctor has many patients to see, and it's not an excuse. We need to fight for this. We need to fight with our managers to make them understand that just a few minutes for a patient who is going to receive a serious treatment is not enough, because it's going to happen what you were just saying. You feel like, okay, you're just one more of a big pile of paper. Somebody answered that, and it's true. So we need to work being able to have enough time and quality time, because it's not any time. Clinics sometimes are like busy spaces, and a neurology clinic, people going in and out, people doing a cystoscopy nearby, the nurse coming in, doctor, there's a call from here, then the door opens 3 times. That's not good. We need to work to improve that. That's our reality, but we need to improve. So very interesting data. Thank you for the effort, and I take home a few messages to work on.
Thank you. And so, yes, excellent. Excellent insights. So now if we look at the European and international policy perspective, what did you take away from the survey results?
Yeah, thank you. And again, congratulations on a really excellent survey. I found the results, reading through them, really interesting, and listening to what Alex had to say in his presentation earlier. And it struck me while reading through that call to action and the results of the survey, how relevant they are to certainly the European and international policy agenda. I work in and live and work in Brussels, so I'm going to focus probably a bit more on the European Union, but I'll touch on some of the international themes that I know as well. So I think, obviously, the initial thought that came to mind was the link with the Europe's Beating Cancer Plan, which was announced in 2020 and is really in the implementation phase now. But that early detection theme is definitely going to be quite current. The part of this Beating Cancer Plan is a revised document on cancer screening recommendations. We believe that currently the cancer screening recommendations focus on 3 cancers: breast, colorectal and cervix cancer. We believe that 3 additional cancers will be added, prostate, gastric and lung cancer. But what might be really interesting is to see what the Commission can do with this recommendation to push towards early detection of more cancers, because there's obviously a lot of cancers that aren't going to be dealt with in this recommendation and in this guideline. And another issue that really I thought was very important was access to treatment, and this kind of the lack of information and potentially the lack of access to a real sort of good multidisciplinary team. The Commission is also, as part of the cancer plan, working on making sure that each member state has at least one, and in some cases more than one, comprehensive cancer centre within each country, and looking at what that means, and also providing the information from the survey to give greater depth in what that means for bladder cancer patients. And the other area of financial toxicity, the Commission is also, as part of the plan, working on a code of conduct on the right to be forgotten for cancer patients. So this is another part of it. It's not only, I believe, when you have to give up work for your cancer treatment, but going forward with the label of cancer patient, it can be really difficult to access certain financial services, like, for example, I don't know, mortgages and insurance and loans and stuff like that. So the Commission believes that this is an injustice and that something that should be done about that. So there will be a code of conduct for financial services, and this kind of information that you've given that the survey has is really, is of direct relevance to policymakers that are implementing that code. I could go on and on, but there are a few highlights that I thought. And more broadly than the cancer plan, you also have like global health strategies. In fact, the European Union has an open consultation on global health strategies, which is very much in line with WHO initiatives, and that making that link between environment and society and climate change, and you have there this link with infectious disease as well. So it's the results of the survey feed into that and are really important for that. And just yesterday, the Commission also launched a care strategy, which is about formal and informal carers. And I don't think they mentioned the word cancer in there, so that's maybe an advocacy idea about using the results of your survey and the findings to show that there is a direct link between cancer and informal carers and the impact on quality of life.
Thank you, Sarah. And Stephen, can I invite you to give the industry perspective on these results and what they mean?
Sure. So firstly, thanks for inviting industry along. Quite often people are a bit sceptical about industry, but certainly we're here as a partner. I have to say a huge congratulations. I know the other panel members have congratulated you on it, but if you think back to 3 years ago when you started, if you would have thought that you would have been producing data like this now, actually you should feel really proud. So from me, a huge congratulations. Sorry, my throat's a bit sore. So I think for me, the things that stood out from the data, it has to be the low awareness of this disease. I think when you look at it, it's one of these cancers that people quite often question. We did some recent work we published back in May as part of Bladder Cancer Awareness Month, which was looking at understanding both patients and caregivers in terms of what they thought about cancers. And quite often, some of the feedback we got from patients was that when they spoke to or they told people they had bladder cancer, people would question it. Are you sure you've got bladder cancer? Does that exist? Are you sure it's not bowel cancer? And you've got confused. So for me, awareness is a huge, huge issue. We need to keep driving it forward. It's interesting, the case that you just mentioned, or a friend of mine, an old school friend, I hadn't met him for years, and I bumped into him a few weeks ago, and he said, we're just talking generally about things, and he said, oh, my partner went to the GPs, and I said, oh, what was wrong? And he said, oh, he's peeing blood. And I said, oh, wow, okay. I said, what happened? And he said, well, they think it's probably just a urine infection. So this is a man who is 60, early 60s, heavy smoker. And of course, my alarm bells are ringing, and I'm thinking, what do I do? Do I say, actually, maybe you go back and rediscuss? And so I said, look, mate, if I was you, I'd maybe go back and look at saying, is there anything else we should be thinking about, rather than trying to alarm them? So for me, I think awareness is a huge thing that's come out of it. And especially because, not only for men, but for women, these missed opportunities for diagnosis are a real challenge. So that repeated visits to the GPs before actually maybe something is picked up on. The second thing was around caregivers. Absolutely. I think they're a population that are so overlooked. And again, some of the pieces of work that we've done recently mirrored that exact same thing. In fact, in the work that we did, it actually said that the caregivers and the patients ranked the caregivers' needs above their own. So both of them wanted to make sure that the caregivers were at the forefront when it came to prioritising services and information and support. So for me, it's a great, it really does highlight that these are, again, probably a disadvantaged population, an overlooked population, but a population that need more help, support. Nobody chooses to be a caregiver. Nobody chooses to do it. But certainly in diseases like bladder cancer, there's a huge burden put on caregivers, so we need to be mindful of it. And then the third and last thing is just more generally around evidence generation. If I look at the last 6 months, I've seen 3 or 4 data sets, or 2 or 3 data sets actually, and one to come as part of Urology Week, which really does highlight that people do not understand enough about this disease. So I think it's a moment in time. I think you guys have done an amazing job at really pulling it together. There's so much work there. What I'd want is to maintain the momentum, keep it going, and look at how you take that forward. And it goes back to some of the work that Sarah, you were talking about. All this evidence will drive evidence-based advocacy and policy decisions. So where you can and where there's opportunity to do so, I think you should really look at taking it forward. And I know you're already discussing some white papers already around it. So again, my congratulations.
Thank you, Stephen. So a question for you, Lisbeth, online. One theme that we heard was a lack of signposting to patient organizations. So many of us exist around the world to support people affected by bladder cancer and their caregivers, but many patients and caregivers are unaware of the existence of these support groups. How can we improve signposting to patient advocacy groups and patient support groups? You're on mute. You're still on mute. Let me double check what it says. I think we need the technicians down the back to unmute Lisbeth. Okay, we will come back to you. These are one of the joys of hybrid meetings. We'll come back to you with that question. Next, Dr. Duran, from your perspective, I'll ask you the same question. How can we just improve the general health literacy of patients? How can we make sure that we have more informed joint decision making rather than it's more of the traditional paternalistic approach?
Let me expand a little bit on my answer, because I'm going to take it from what he commented. You've done a great job, but the job doesn't finish here. So this is like what we learn from what we call lone survivors in oncology. And so for many years, and there was an American patient who was, let's say, the guru of long-term survivor. And he used to say, when he would explain the feeling of long-term survivors, he said, this is like if you're drowning in the water, somebody saves you, brings you back to life, and then leaves. And then you're there, you know, like, okay, what happened? No, it's not enough. Well, so let's make a similar comparison. You've done a great job, but it's not enough. Now we need to disseminate this, and this is a perfect tool to stimulate other countries and other groups to bring things together. In Spain, for instance, is the country that I'm representing here, we have a serious lack of patient advocacy groups around bladder cancer, and you know that, and it's my interest that we're able to create one. And so, you know, we need to work around that because patients really need it. And I think these kind of groups have a role in the whole structure of treatment. And healthcare professionals, we can do so much, but we cannot cover everything. And you guys do a big part of the equation. So my question is, how do we do this? Because you guys have built very nice material. I was reading those booklets before the meeting started, which is one way to communicate. But I mean, it's a huge challenge. So I'm very happy, open ears, to bring back some ideas to Spain and see how we can create those groups in other places.
Thank you. I'm going to ask our IT guys. No. Okay. Give me a thumbs up when we have that back. So, Sarah, many of us in the room, we started off as just a small patient support group. So, unfortunately, us or someone that we loved was affected by cancer, and then we just gathered together other people in the same situation. And then, so you've got these small groups in these small countries. And then what you have is you've got these monolithic institutions, the World Health Organization, the European Union, the European Parliament, even national governments. You know, the prime ministers and the presidents seem so far away from where we are. And we know that change is needed, but we feel so small, and these government and international institutions feel so big. So how can member organizations of the World Bladder Cancer Patient Coalition and the World Bladder Cancer Patient Coalition itself, how can we change politicians? How can we engage in advocacy and change policy?
Oh, I could give a lecture. I don't know. So I think one key strategy is to join forces. Because reading some of the the findings of this report, this is obviously, some of them are shared findings with other cancer patients, and so I guess it's to build alliances with other cancer patients, but with also the broader cancer community and broader patient community, and there you've already got some economies of scale. And obviously with professional organisations like the EAU and the other disciplines involved.
And the EAU is the...
Sorry, the European Association of Urology, for whom I work as the policy lead. But quite often, although these organisations like the European Commission or the WHO seem like huge monsters, and they are, but it often just takes one or two key relationships and to foster the alliances and allegiances that you need to go forward at least one step. You might not go forward a giant leap, but you go forward one step and keep focused on maybe one theme. Florence from the International Agency for Research on Cancer is here. So that's a WHO agency based in Lyon, France. She's here today. She's a really key contact for you going forward, focusing her research on a biomarker for bladder cancer. And you make links, you form the partnerships, and you can't be experts at everything. Sometimes you offer your support to other people's campaigns because you know that they've got the evidence behind what they're saying, and sometimes they know that you've got the evidence and they lend you their support. you know, we work with the European Cancer Organisation and all sorts of networks in Brussels and throughout the world to try and promote urology in general, but better outcomes for our patients.
So I think it's just remembering that we're all human beings trying to do our best, and even in these big institutions, there are human beings inside these institutions, and just build those connections.
Yeah, not to be too afraid about reaching out and sometimes using that intermediary of another organisation or another membership organisation that can help facilitate that.
Thank you. Stephen, what is the role of the pharmaceutical industry in providing support to patient advocacy groups in raising awareness of bladder cancer?
To me, again, it's about alliances, it's about partnerships. It's about, I don't know, forging ideas, generating ideas, being creative, looking at opportunities. Quite often you got to look at pharma companies, and I don't know if there's any other companies in the room, but we're global companies. We've got lots of opportunity to try and engage or encourage local activities and support you when you're trying to do it. I know we've had talks around groups and certainly in Singapore and some other countries and regions. And again, that's where we can help. That's where we're there to help. It doesn't always have to be about financial contributions. But use and partner with us as a vehicle to help drive and support the activities that you're doing that you want to move forward. And then the other thing I always think, like with anything, which you've just done, is evidence. And where we can support that, we're happy to look at doing it, because that, I think, raises your profile when you do go to knock on the doors of people like WHO, and you need to have it backed up by evidence and the advocacy behind it. So for me, that's where pharma companies, again, can help, whether it's through knowledge and experience, or whether it's through joint working around trying to generate things like the surveys that you've just done. Again, we step back from it and you independently drive it. It's not for us to drive it, as you've shown today. So yeah, it's about partnership and alliances for me.
Thank you.
Don't you guys think that, in general, this is for all the speakers, we are putting a lot of effort maybe too late, and we're not putting a lot of effort and investment in early stages of the problem. And one of them would be education. If we educate our society, and when I talk about educating, I'm talking about high school like level, and teach people. How many students at the high school level know that there is a connection between smoking and bladder cancer? Probably very few. And some of them probably smoke, and they ignore that. So I think we should go back to education as a fundamental, tool in order to improve outcomes. The second step that many times we forget is prevention and early diagnosis. And, we spend tons of dollars and euros in treatments, very sophisticated, fantastic treatments, fantastic operations, but many times we're not spending money in just telling people, do not smoke, or if you have this symptom, look for attention. So I think those two stages are somehow a little bit, I wouldn't say abandoned, but they don't receive so much attention. Probably it's not as sexy to run a project in, education or prevention. It's more sexy to, be the best surgeon or to deliver the best treatment as an oncologist. But I think we need to keep that in mind.
Thank you. Do we have Lisbeth back now? Amazing. So if you could just offer your perspective on how we can improve signposting to patient organizations.
Can you hear me now?
Yes, perfectly.
Great. Yeah, I think there's a huge role for patient organizations and for fellow sufferer support. We see that especially patients with during the time of their diagnosis, they want to hear from other patients what their experiences are. We can give them a lot of information, and we have good contacts, and I now talk, I'm sorry, only for the Netherlands. We have very good contact with the urologists and oncologists, medical oncologists, and we can see what kind of treatment is perhaps the best treatment, and what kind of hospital is perhaps the hospital where they should go to, depending on what what kind of information they want to have. We can help them with shared decision making. So there is a lot we can do, but patients should be able to find us. And I think there is a role for doctors and specialists to point out how important it is for patients to reach out to a patient organization and know how important it is to share information with other patients. And that in the beginning, perhaps that sounds awful, because what kind of information can you have from other patients? But it gives you, it is very nice and educational for patients to talk to somebody who speaks their language on a patient level.
Thank you, Lisbeth. In the 9 minutes that we have left of this panel discussion, I'd like to open it up to the floor as well, both online and in the room. So if you have any insights, comments, or questions, I just ask you to raise your hand, and Theodoros will give you the microphone.
Thank you. First of all,
can you introduce yourself, please?
Sure. So I'm Michelle Calero from Bladder Cancer Canada, and all of you, thank you for your time today. The findings were so impressive. We started to think about doing a survey in Canada as well, specifically after diagnosis, and tying them together, I think is very valuable. And I think there's a lot of key learnings. And for us, it's all about collaboration. It's collaborating with pharmas, with doctors, with urologists, with everyone. Is there a specific strategy that you would suggest reaching those GPs to maybe remind them that females, it may not be a UTI? Because I'll tell you, we get so many calls from women who are really frustrated and angry that they had a UTI for a year and it turns out it wasn't a UTI and something was missing, obviously. So any suggestions would be great.
Well, I think our next presentation, we have Dr. Stephanie Demakew answering exactly that question and her initiatives in Australia. So we will look forward to hearing about the amazing work that you've been doing in Australia to make sure that GPs are aware of hematuria and what to do about it. Yes, next. Could you please introduce yourself?
Good afternoon. I'm Lauren Pretorius from South Africa. Being from a low to middle income country, we're often in the room where we have the honor of having patients diagnosed really late most of the time. And in bladder cancer, I think that's one of the things that we find throughout the world, that there's a commonality on that. You mentioned that there was a shortage of advocates within Spain and patient advocates. How do we work to identify those patient advocates that we can then take perhaps under our wing and mentor? At the end of the day, you've got a room full of professional advocates that have walked the walk and seen it. So how do we find those people, and how do we do that?
So if there is a patient advocate in the room who would like to briefly, in 2 sentences, share their story. Yes, Lisbeth, can you answer that? How did you become a patient advocate? Alas, Lisbeth, we have lost your sound again.
Oh, again.
Oh, no, you're back. Hooray.
Okay, good. Well, I have been a patient advocate for a great number of years, and and we had some experience in twinning projects with other countries. And it is, some countries can work together with countries who are new to patient advocates. In Europe, we have education possibilities for patient advocates, and we are quite, as the Netherlands, we are quite happy to work together with other countries to help other patient organizations and patient advocates to make the utmost of their work.
I was just going to say, I'd say the breadth and depth of my experience in doing pharma work with advocacy groups came from HIV. So for years, we worked with the European AIDS Treatment Group. And one of the things that was becoming apparent was it was almost like succession planning, because, no disrespect, there was a lot of older gay men that were advocates that were kind of dropping out the advocacy scene. So we suggested to them that we help through other companies as well, so not just us, fund it was an advocacy training program effectively called Step Up. Kind of like UPATE, but much more focused on the disease, so it was much more disease specific. It was run by them, it was funded by industry, we stepped back from it. But for me, again, these are great initiatives that look at bringing people with the knowledge that they've built up over the years, but sharing it with new and young advocates that might be wanting to come through. And quite often we found there was people that were not necessarily living with HIV, but affiliated, maybe caregivers or people that have gone through that experience with a loved one who wanted to then go and do advocacy. So there's maybe scope in doing it, and I'd happily share with you how we went about it and supported them.
Thank you. And this brings us to the end of our session. So thank you very much for all of our speakers online. And we're moving to the next session, which is to hear from some of our member organizations. So thank you very much for sharing your perspectives. Thank you. Yes, so we will have three of the member organizations of the World Bladder Cancer Patient Coalition share their perspectives. One from Australia, one from Italy, and one from Canada. And one of the goals of the World Bladder Cancer Patient Forum is so we can hear about the exciting initiatives that our sister organizations around the world are conducting and learn from them and hopefully be inspired. So I am very excited to welcome our first speaker. So our first speaker here is Michelle Calero, who has traveled all the way from Canada, and she will be speaking about the Canadian Bladder Cancer Information System. So Michelle, I invite you to come up and please share this amazing project with us.
Thank you, thank you. Gosh, that's an old picture. It's a very old picture. As my colleague Ken from BCC is laughing the loudest in the room. So thank you very much. Nice to see everyone, and nice to see you online as well. I'm just going to click and hope it moves on. So I'm talking about CBCRN. As many of you know, we live in an acronym world. So CBCRN starts, I feel like I should ask if anyone knows what that is, but you won't. So it's the Canadian Bladder Cancer Research Network. But before I talk about it, I first need to talk about CBCIS. Again, looking around the room, no one knows what that is either. So CBCIS is the Canadian Bladder Cancer Information System. Again, it's also a big wordy word. Really what it is a repository of information that 16, almost 20 centers in Canada now contribute to. So that means all this data from diagnosis to treatment is entered into a database, depersonalized, so there's no information specific to the patient, and is entered into the system, the CBCIS system, to find ways that we can better improve diagnosis, whether it's treatment or whatnot, and how do we find treatment successes or treatments that are not always successful. So the goal, identify gaps in bladder cancer care, evaluate unmet needs, and improve the management of bladder cancer patients. The database, as I said, collects depersonalized information, bladder cancer history, medical information, practice outcomes, patterns, treatments. And so we've got all sorts of data systems. We started with just a few hundred, and now we've got, gosh, at last count, we had about 10,000 patient information contained. And then the doctors, all being experts in their field, of course, said, well, now what do we do with it? Now, BCC, we started and seeded the original CBCIS database system. And it's our medical advisory board that came together with a team at BCC and said, we've got amazing data. Wow, there's some patterns, there's some improvements, there's changes, but what do we do? Thus the creation of CBCRN. It's using that, I'm okay with him crying throughout my presentation. How can you not? He's adorable. So the goal is now to leverage common strengths to optimize patient outcomes. So what does that mean? It's building on the data from CBCIS. So we've got some successes that we want to expand and build upon, and what will that look like? And then we've got some perhaps deviations from some of the research as well. We also are looking to collaborate more fully and internationally. There's few urologists in Canada, quite a few more urologists in the US. So rather than having two separate research teams, is there a better way to collaborate and share the outcomes from CBCIS? It's also, again, promoting research, training, prevention, all, of course, improving patient outcomes. Oops, I think I skipped. No, I did not. I did. I am not tech savvy. I'll be the first to admit that. There we go. So it's also, as I'm sure many of you are aware, the scientific advances change. You know, what we think is really amazing potential today, you wait 20 minutes sometimes, and it changes. And going to think tanks, having patient forums like this is a great opportunity to say, oh, what are you working on? What are you working on? Is there a way that we can collaborate? So it's advancing them forward, and our medical advisory team, specifically our chair and vice chair, Dr. Peter Black, Dr. Wes Kassouf, and Dr. Girish Kulkarni, I mean, they are connected to the Cleveland Clinic, the Mayo Clinic. Like, they know what's happening in their respective communities. So what is it that we can use this research from CBCIS to pull together and find other ways that we can solve outcomes and improve treatment? And then, of course, it's facilitating the dissemination of knowledge throughout the Canadian community and engaging patients, their caregivers, and families in the research process. So I'm looking at Lydia for time. Oh, I have 5 minutes. I will sing and dance now. Did anyone have any? I don't do either of those. Does anyone have any questions? Yes. Oh, hold on.
Hi, I'm Molly Ingersoll. I'm a bladder cancer researcher here in Paris at the Institut Pasteur and Institut Cochin. I'm not French. I'm actually from the US, and I've been working with Beacon for a long time. What I'm curious about is, I really like this idea that you should be expanding and working together, so you're not sort of doing the same thing over and over, country to country. But I think about the contrast in Canada and the US and the healthcare system, and I'm wondering, just basically, what are the challenges that you're facing when access to healthcare or insurance for some of these are so different between the two countries, and whether that's something that can somehow be bridged, alleviated?
We have talked about it. It is, there's a huge disparity, and there's a big issue if we take BCG, for example, and the issue around the availability of BCG. So we are aware that we've got to figure out a way to do that, but if someone is studying one specific finding, and I know Girish is in particular right now, he's working with the counterparts and not necessarily concerned about the insurance at this point. It's really a matter, not that he isn't, don't tell him I said that, but it's more now what and how can we better leverage it using the information in CBCIS. If we've got a patient who went through, say, immunotherapy, had great successes, and a patient with the same characteristics and experience, but they don't, you know, how in that case are we solving a gap? Is there a gap? I should have started by saying the CBCRN started a year ago. So we're very green. We've got a steering committee that we're really getting started. So stay tuned, and I can report more at the next forum. And keep in touch, and if you have any other questions, let me know. Thank you. Oh, another question. I'm in the hot seat.
Hi, Tony from bladdercancer.org.au in Australia. We heard earlier that about 74% of patients seem to go down the cystectomy route. I think that was correct, wasn't it? Mm-hmm. Can we get any data on survival rates for people who don't go down the cystectomy route? I mean, cystectomy is obviously a tried and true way to help people live after bladder cancer. Can we get some stats about what happens to those who don't go through cystectomy and all the different treatments and what their survival rate is?
Mm-hmm. We're working on so we had some changes in the project management piece of CBCIS. The project researcher lead actually retired. So now we've filled that role, and now we're looking at pulling information such as radical cystectomies, success or perhaps not success, what is defined as success as well. So it's also some of those quantitative markers that we're trying to identify. Some people may think they had success, but again, it's what is that based in compared to someone else. So we're working on all of that. Oh, okay.
Well, thank you. No, I just wanted to add to what you said, that Dr. Slaughter, who is a neurologist practicing in Canada, presented very interesting data not so long ago, comparing a population of patients who had cystectomy versus those who had bladder preserving strategy, and the outcomes were actually superior to the bladder sparing patients. This is a retrospective analysis. It generated a lot of debate, but at least it opened the discussion about whether we should be operating every single patient with muscle-invasive disease. So this is still an open question. Of course, the work of Alex Lotta is not going to resolve it, just one big retrospective analysis. But I think now we in the uro-oncology community are more aware about how relevant it would be to develop strategies where we preserve the bladder when it's possible.
Thank you. And Dr. Zlata is, I mean, the whole team there is amazing. We are missing some information from community hospitals, though. We've also identified that we've got to add other and more information to that. And thank you.
Thank you, Michelle. Really fantastic work, and I think that we can definitely learn from what Canada is doing, and hopefully one day this will be an international information network and not just a national one. So thank you very much for sharing that information, and it's great that we have these personal connections, so we can now build upon that as well. So now I would like to welcome Laura Magenta, who will be talking about the EuroH Angels, which is about how we can match people up to make sure that someone who is facing some serious surgery is supported by someone who has followed a similar clinical path. And you are representing Palinuro in Italy. Thank you.
Thank you. So my name is Laura from Palinuro, the only association in Italy which is helping patients with bladder cancer. And I am a patient too. I had my radical cystectomy 6 years ago, and I had a neurostomy, and now 3 recurrences in 3 years. And a cycle of chemotherapy just terminated. So I am a patient, okay? And we have seen in the survey before about the fact that no one offered at the hospital an help to patients. And we know that for patients with a severe tumor or with the prospect of having a radical cystectomy, it is essential that they are supported by people who have followed the same clinical path before. Interacting with the volunteer and having an healthy appearance and a positive mood is completely different and complementary to the support contribution offered by health professionals. Our effectiveness is closely linked to the expansion of the number of hospitals and the consequent need to have an adequate number of volunteers for this purpose. And this is why, the reason why in 2099 is born the project we named Euro H Angels. That means angels in the urology department of the hospitals. Our dream is to be present in every hospital where there is a patient who needs us, or at least to let him know that we exist and that we are available to him. So we start an expansion program with accreditation at major Italian hospitals that have an onco-urology department within them, which has resulted in agreements with the following hospital. I don't mention each hospital, but you can see 11 hospitals, 9 in the north of Italy and 2 in the center of Italy. And then the problem was that for almost 2 years, due to the pandemic, we have not physically managed to set foot in any hospital. Even all the planning linked to the collaboration with hospital, posting, for example, our posters, sending our brochure and booklets for patients, has stalled. And from the second half of the past year, the new hospital has shown their interest in collaborating with our association. Other 6 hospitals, so we have other 2 in the north, other 2 in the 3 in the center, and 1 in the south of Italy. And we also start a training program for hospital volunteers in order to deepen and regulate the approach to the patient and caregivers who want to know. They want to know in a simple and familiar way. And Palinuro wants to transfer their experience. Bladder cancer patients are the most valuable source of information and example that the disease can be overcome. And we, me and some people in this room, are people that live with the disease and have our own experience with bladder cancer. But how do you become a volunteer? There is a list. I don't want to read all. In any case, volunteers must submit their candidacy to the presidency of the association, which will verify the presence of some requirements. For example, the first one, you must be a patient with bladder cancer, or a caregiver, but mainly a patient, okay? And then have time to devote to volunteering, and mainly you must regularly attend the training course which provides the basic tool and information essential to carrying out a volunteer activity. So we deal for the training of the volunteers, and we have now 25 trained volunteers, but at the moment, only due to the pandemic situation over the past year, only 5 are operating in hospital, which means that they attend them regularly in agreement with the medical staff. Others volunteer now carry out telephone and online support activities through our self-help groups or Facebook. So our primary goal is to grow. So what we want to assign at least 1 volunteer to each accredited hospital. We want to carry out the 4th course for volunteers Palinuro, plus the Italian Association of Cancer, which has a particular course dedicated to volunteers. It's a national one, to complete our course. We want to conclude the accreditation process with the structure of the progress and lay the foundation for new accreditation and agreements to be completed in the course of the next year. This project involves some cost. For example, the cost to the volunteer course, our visit to the hospital, to the urologist, to the oncologist, to finalize the collaboration, so travel expenses, possible room and board, shipping of the literature to the hospital, reprinting the literature based on the request of the hospital, the volunteer insurance, reimbursement of any volunteer cost incurred on site for information and awareness raising activities. That's the reason why in our website there is a dedicated page that where we describe the project, and we invite people to support this initiative by making a donation. Thank you. Thank you very much.
Laura, we have the time for questions and comments. Laurie, could you speak slowly, introduce yourself?
Yes, I'm Laurie Serafis from Cancer Vessie France. Laura, how did you develop your training course?
In sense, we choose, for example, 10 volunteers, and they come in Milan, and we have prepared a manual. All the day we stay together, and we talk together about any possible aspect to be a volunteer with another person. So. Psychological aspect and so on.
Did you have input from other organizations to help make the manual?
Yes, we had from the main association for cancer in Italy, which is LILT, and we tried inspiration from other manual in the same in oncology. So we put together our manual, and we asked the main organization to approve it. Okay.
Thank you.
Slowly.
I will. I promise I will speak really slowly.
Thank you.
Scottish people are never easy to understand. So my question is, this is great, it's really wonderful. Have you captured data on the outcomes from the patients that were involved? So do you have information on like satisfaction and how it's being used?
Not yet. Sorry. Not yet. We don't have yet ready, but we want to do so. Yes.
Yeah. No, it's great. Wonderful.
Okay.
Thank you.
Thank you.
Thank you very much, Laura. Amazing work. And now from Australia, we have Stephanie Demicu, who is a GP by background and is also a carer, or was a carer for her father, who was a cancer patient. And so now please share with us your initiative on hematuria and talking to GPs and family doctors.
Thank you, Lydia. I might just give maybe one of those, and then I'll just, if every row just grabs one and passes it on. I think the baby belongs to me, and I think I was thinking too much about nappies, and I left my huge stack of pamphlets that I brought from Australia on the bed, so you'll just have to share. I also wanted to say thank you, Alex, for putting me last. I'm probably the most jet-lagged person here, so I'm sort of fading. If I seem a little bit delirious, I am. But, you know, the show will go on, and if I'm not making sense, it's because I've come from Australia only a couple of days ago. So, yes, what I'm talking about today is how to treat hematuria, an updated guideline from a GP perspective. Okay, so first off, who am I and who are BCA? So my name's Dr. Stephanie Demicu. I'm a primary care physician or GP, family doctor from Melbourne, Australia. I established BCA with my sister back in 2014 after our father passed away from advanced metastatic bladder cancer. At that time, there was no advocacy group, charity, anything dedicated to bladder cancer, and it was a real void in Australia. So basically, you know, there was that frustration of the lack of emotional, educational and financial support for those suffering with bladder cancer in Australia. So in addition to awareness campaigns, the money that we raise from our various fundraising initiatives has been used mainly to bring patients and caregivers together. So we run events, we run activities, we've started to run retreats as well, little getaways. And our other sort of big money spender is we financially support the terminal patients in terms of their treatments, their palliation, or allowing them to tick off items off their bucket list while they're still well enough to do so. So I've got a couple of pictures here. One's just showing you that I am a real doctor down the bottom. And up the top is my sister with a patient called Andy who unfortunately passed away, but before he passed away, he had a page called Andy's Bucket List, and one of the things that we funded was for him to see some of his children in New Zealand before he died. So that was a long time ago, actually. That was just quite early in our charity, so that would have been probably back in 2014. Here's another couple of pictures, because I don't know, I kind of like to make it colourful. Picture of my dad and my baby sister. This is a picture of Dad in hospital. Still had pretty good hair. I think he was still using a lot of products when he was in hospital, but there he is. You can see he wasn't very old, in his 60s. And this picture was from a couple of days ago. So I put this up because I thought on a scale of 0 to how much do you care about bladder cancer, dragging 4 children under 7, 24 hours on a plane is the score. So whatever you'd give that. Personally, I'd give it about a 12 out of 10, but everyone is different. And another little couple of pictures from our organisation. This is from the retreat that we recently held in Healesville. So we had about 40 patients and caregivers, lots of activities. I think one of the things that the pandemic really showed was that lack of people really wanted to connect again, and they wanted to do things in person. They were Zoomed out, they wanted to get together, and that was a really powerful experience for me and I think for everyone who was there. Okay, so back to my project. So as we know, hematuria is very common, urological presenting complaint, and you know, it has been an issue in general practice, as we've been talking about pretty much the entire day. I was sort of like, that'll come later. You know, it is an issue that there is no sort of clear guidelines for GPs, I think, in a lot of parts of the world on how to approach when a patient comes in, sits in front of you and says, I've seen blood in the toilet, or they've come in with something else and you've done a dipstick test, which is a little paper thing into the wee cup, and it's come back lighting up that there's blood in there. So what we did is we had a group of a few of us, and they were some of the leading bladder cancer doctors or urologists in Australia, myself from primary care, and we reviewed a whole lot of guidelines from overseas, which are, you know, pages and pages long, huge documents. I know myself as a GP, I kind of looked up a couple of them and I was like, whoa, this is way too much. So we wanted to make a user-friendly summary for GPs to use to send them down the right path of how they're treating these patients. So our research was published last year in the Australian Journal of General Practice, which is really exciting. The pamphlets look like that, nice aesthetically pleasing pink pamphlet. So if you have a look at what we've passed around, we kind of go through you know, the causes, the risk factors. We go through a lot of the benign things, just for kind of to have a checklist of what GPs need to be thinking about. Woo! All right, let's move on. The algorithm is probably the most useful thing, I think, from a GP perspective. You know, GPs want to go, okay, well, this patient's come in, what do I need to do? So we've got a lovely flowchart where you know, okay, we talked about micro and macro hematuria, so, and where you go down the pathway, so what tests you need to do. But I'll let you have a little look at that in your own time. This is all on our website as well if you want to have a look. And then we came up with key points for the GPs. So as a GP, I love key points. I love seeing a little paragraph at the back saying these are the 5 things you need to be thinking about. On my board exams as to become a GP, one of the patients or the actors I had in front of me came in and said, hey, I've got hematuria. Or well, they said, hey, I've got blood in my wee. So that was a really exciting day for me, actually, because I was like, well, I know exactly what to do with you. Yeah, so anybody have any questions? Nothing tricky, because my brain is a little bit mushy, so.
How are you getting this brochure out to GPs?
So this brochure, so we published the paper last year. This brochure is fresh. You're the first people to see this brochure, which is very exciting. So our plan initially is to go to the GP training colleges that are all, there's one in each state, or some states have a couple, and roll it out with the resident doctors who are training to become specialists in general practice. They're the ones who sort of, I think they're studying this, they want to be up to date. You know, it's an overwhelming thing. You know, I don't know how many GPs there are in Australia, but there's a lot. So that's one way that we can make it manageable and kind of target, you know, a manageable number of GPs at a time.
Well, congratulations for this initiative. I think is great, and we've been talking about education before, and I think these are the kind of things that would help. I don't know if you guys are considering also having this in an electronic version, because brochures, you may lose them, but if you have a web page where you can go and in 2 clicks.
They're already up.
There? Okay, that's great.
Thanks.
Thank you.
Hello, I've sort of got a question. So I said earlier that it took me a long while to get diagnosed, and I had visible blood for a year. And when I contacted my GP, I was allowed to, he was a bit busy, so talked to me on the phone, I was allowed to diagnose myself as having a cyst that burst from goodness knows where. So, you know, sometimes it's quite hard to get the GPs to listen, but I wanted to tell you about, we worked on a campaign, Blood in P, which was on the television. Yeah. And if you see this, then you go to your GP. Shortly afterwards, I was at a conference, and this happened more than once, and we was quite surprised that nurses came up to us and was annoyed that after this campaign, people have been seeing it, and they've been seeing far too many people. And most of them haven't got bladder cancer. And they was really cross, and I was taken aback to have that kind of reaction. I mean, would you think it's better to send people for some kind of checkup? As a cystoscopy, you can really see what's going on.
The whole point of the campaign was to get them presenting.
Would this kind of reaction make people feel, or a GP feel reticent to send somebody if they was getting that kind of remark? Because these were genuine remarks that I heard from professionals.
I think from a GP point of view, if a GPs, they know something about everything. You know, they don't know, the specialist like a urologist knows everything about something, everything about urology. GPs have to know something about everything. So giving them something that's easy to use, a no-brainer, they love that. Honestly, they do. So it's like, well, I just tick what I need to do. So, I'm very disappointed to hear that was the reaction, because that was the whole point. We want people to come forward. Yeah. So that's really disappointing, and I know your experience was horrendous as well. So I find that quite mind-blowing. A year is a very long time.
You educate some, obviously, we know GPs as well, and they can't cover everything. There's a lot to cover when a patient comes in. But, you know, educating the GPs is really important, and to know that it's not just the high-risk people that they're expecting. It's women and, you know, all kinds, not just a menstrual problem. It might be people that don't have that issue at all to worry about. So
the other, adding on to that, the other thing I tell patients is you can change your GP. If you've had a GP for 10, 20, 50 years, and you think there might be a GP who might click better for you, you can find a new one.
You can. It's a little bit harder than
you know, because sometimes people feel very, even if they don't really like their GP that much, they feel very, oh, well, I'm very loyal to this person because this person saw my mum and my mum's mum and blah, 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 blah. You don't, there's, you know, I think you should feel heard by your GP, and you should feel like everything, you know, they're taking the time with you, and you walk away feeling like your concerns are addressed. And if there isn't enough time for you, you know, some people come with a list of 20 things. We pick out the most, you know, what's the most pressing, and then we make a time for them to come back. So
yeah, I can see Lydia getting nearer to you.
Thank you.
Amazing. Thank you, Stephanie. And so in the last 5 minutes of our day, I would like to invite Alex for his thoughts on the summary and conclusion.
Thank you, Lydia. I don't think I'll need 5 minutes. I realized that we're on time, but I just wanted to, first of all, say thank you to everyone who has joined us here today in person, especially those who traveled so long and stayed with us throughout the whole day, but also everyone joining online from many different countries, patient advocates, healthcare professionals, everyone I think contributed so meaningfully to the discussion. We're super excited and thrilled to be presenting the findings of the survey today. You really got a snippet of it all, and there's much more to come. And we hope, as the panel discussion have shared, will be a starting point for us to work from there, and we don't stop here. And so there's a lot of the wealth of that information that so many patients shared with us from across the world, from their own experiences, is what will guide us now in the future in terms of our work together as a coalition with all the members and also all the stakeholders, I think healthcare professionals, and so great to have you here in the room with us as well. The fantastic projects as well that we saw just now from Michelle, Laura, and Stephanie. Thank you so much. I think it showcases the breadth of activities that our members undertake, and also the level of professionalism and comprehensive activities and projects that you take, and that you work with so many stakeholders as well. And these are just 3 examples of many more that our 12-member organizations at the moment in 9 countries undertake. And as I said earlier, our biggest mission point is really to help support in the establishment of strong bladder cancer patient advocacy groups in every corner of the world. So no matter where a patient lives, they have someone to turn to, someone to speak to, and get the quality of care information that they truly deserve. So thank you so much, everyone, for being with us here today. We have a few posters on your way out here where you have an opportunity to share some thoughts, some feedback, and any ideas that you have for the future, but also thinking for the future. What would you like to see in the next 5 years for our bladder cancer patient community when it comes to change? So I invite you to share those thoughts on the posters on your way out. Continue the conversation together, and online as well. Please do feel free to share your thoughts in the chat as well. Thank you so much, everyone.